Hello and welcome to Best of the Day from the 2015 Great Debates and Updates in Hematologic Malignancies. We're meeting this afternoon with Dr. David Steensma from the Dana-Farber Cancer Institute. We're going to talk about some of the presentations from today's meetings regarding CML and myelodysplastic syndrome. So David, welcome once again to Best of the Day. It seems like you and I get together on a fairly regular basis for this sort of thing.
Thanks, Jim. It's always good to talk with you. It's always enjoyable, and there's always new things going on.
There's always new things going on. So let's talk a little bit about CML. This was an interesting but a somewhat different and unusual session in that it wasn't the typical imatinib versus nilotinib or versus dasatinib sort of debates. There were three lectures. One concerned the role of transplants. One concerned the cardiovascular risk with TKIs. And the other concerned, I think, a very timely topic of monitoring the biomarker, the BCR-ABL transcript, and what to do with that data at 3 months, 6 months, 12 months, 18 months. So let's talk a little bit first about Javed Mosley's presentation. He's a cardio-oncologist, which I'd never heard of, but a trained cardiologist who mainly works in the field of oncology and dealing with cardiovascular complications in patients who are on, in this situation, TKIs for CML. Right. So give us a sense of what his thoughts were.
You know, cardio-oncology is really a maturing field, and we've traditionally thought of our cardiology colleagues in the context of when we use anthracyclines, right, or for those of us who treat breast cancer, Herceptin, and some of the complications that can occur with those sorts of agents. But as we're learning, many of the tyrosine kinases that are used for various diseases, renal cell cancer, hepatocellular cancer, and CML, have important vascular and cardiovascular effects. And so Javed took us through some of those different effects and how each of the TKIs that's approved for CML has distinct effects because their kinase inhibitory profile is different. For instance, nilotinib and dasatinib inhibit VEGF to a different degree than imatinib does, and perhaps that's why we have seen in studies with nilotinib, for instance, more atherosclerotic disease peripherally than was seen in imatinib studies. Ponatinib is the drug that got the most attention around the cardiovascular complications because the FDA actually pulled it off the market briefly, right, because of those concerns. And we don't know, are those dose dependent? Can they be prevented with aspirin or statin or anticoagulation? All very important practical questions that we don't know the answers to right now. But one thing that is clear is that ponatinib has a very impressive inhibitory activity against VEGF kinases and other things that have been shown to trigger hypertension and proteinuria and various sorts of vascular events when we look at drugs like sunitinib and sorafenib that are used in the renal cell cancer setting. So lots more work to be done, but I think this is certainly an area that is one that we need to be thinking a little bit more about. He also talked about how there have been cases of atrial fibrillation seen with ibrutinib for CLL, and the mechanism of that is unclear and being worked out.
Well, and it's unfortunate that in metastatic renal cell, the use of sorafenib and sunitinib is often less than a year. But in CML, patients can be on these drugs for 8, 9, 10 years, and the potential for, cumulative cardiovascular, cerebrovascular, peripheral vascular complications builds up with time.
Definitely. Many of these patients, not all, but many of these patients are going to have great long-term outcomes from the standpoint of their leukemia. So that means we have to really pay attention to some of these other things that are actually almost as likely, or perhaps even more likely, to take their lives, and that is things like management of diabetes and management of hypertension and doing what we can do to prevent cardiovascular outcomes like heart attacks and strokes and peripheral thrombus.
Right, managing their cholesterol and that sort of thing. That was really very interesting. So let's talk a little bit about Jeffrey Lipton's presentation looking at early molecular response. And for the last few years, we've heard about measuring BCR-ABL transcript levels at 3 months, and if by the international standard it's greater than 10%, this predicts a lower likelihood of achieving an MMR or a CMR. There's some guidelines that would suggest that if you don't achieve that less than 10% transcript level, that you should seriously consider a change in therapy. So tell us what Jeff had to say, and tell us what you all are doing at the Dana-Farber with that type of data.
Yeah, so Jeff talked quite a bit about the guidelines for monitoring, not just at 3 months, but throughout the course of the patient's treatment. It was a little bit sobering how often those guidelines are not considered or not followed when looking at survey data from oncologists across the country. But one area where those guidelines do disagree is what to do if at 3 months your patient has not achieved an early molecular response. Some people feel very strongly that the data are so compelling that those patients have a much poorer outcome that should prompt a switch in therapy. Other people say, hey, no, take a step back and see if there's anything else you can modify first before making a switch from an agent that may eventually capture the patient into a deep response. And for the most part, that's been the practice of my colleagues and I at Dana-Farber, is that at 3 months, if somebody's not quite to the 10% mark, we'll assess, are they actually taking the medicine? And we review again the importance of adherence and compliance with the medications. We'll assess, are they on a concomitant medication that could be affecting the pharmacokinetics of the drug? We will assess, are they taking something like grapefruit that with some of the kinase inhibitors can interfere with its absorption and metabolism. So, particularly if the patient's close to 10% but not quite there, somebody who's at 14% or something, I think that's an appropriate approach. But then at 6 months, if they're still not there, then I think that's a compelling reason to think about mutation testing and to think about switching drug.
I was very impressed by the data he showed, showing that if you miss more than 2 doses in a month, that it significantly decreases your chances of obtaining a major molecular response. And that, 2 doses a month, you go out of town for a weekend to see a football game or whatever, and you miss the pill on Saturday. I mean, that's so easy to do. It's patients have to be extremely compulsive about maintaining their daily dose.
It's human nature to miss now and again, but I think one of the important things that we can do as hematologist oncologists is to educate our patients that, especially in that first 6 months or so when the disease burden is greatest and the opportunity for a mutation to emerge, a mutant clone to emerge if the disease isn't adequately suppressed is the highest. That's the time when adherence probably matters the most. If you've been in a complete molecular remission for 3 years and you miss a day or two, it's probably not the end of the world. But if you've got just been diagnosed 2 weeks ago and you miss 3 days in a row, that's probably a big deal.
That's a big deal. That's a big deal. I was also impressed. Someone asked a question about bone marrow biopsies, and he said he does one at baseline, and then another one at 12 to 18 months, and then that is it, unless there's a relapse. And he wants to do it. What are you all doing at Dana-Farber? As I've heard people at MD Anderson say they do one every year, at least for a number of years.
Yes, my colleagues and I think, probably have slightly different practice patterns as far as when we do bone marrows. And my own has evolved during the time. For a while I was doing one every year to keep track of the disease, but I'm now convinced that if somebody's in a major molecular remission, especially a complete molecular remission or an MMR 4.5 log, that's someone who it's very unlikely that you'd find anything on the marrow important to know about. So I typically will do one after the diagnosis, just to make sure that what we're seeing in the peripheral blood correlates with what's going on in the marrow, and then call it quits for most patients.
Right. And the importance of knowing just how reliable your BCR-ABL transcript assays are.
Correct.
Whether or not your hospital is changing labs every 6 months to get a better deal.
Right.
Sort of, you need consistency.
Indeed, it does matter. And we changed a little bit over a year ago from the homebrewed assay, which was actually quite a good assay, but to an assay that used the international standard, sort of the INR equivalent for BCR-ABL. And that was important, I think, to bring us into alignment with other centers, but it did result in some changes in patients' levels that then they had concerns about if it went up a little bit. And so it is important to know what your own local lab is doing.
Well, imatinib initially was called STI 571, and I'm told that Hagop Kantarjian said that STI stands for Stop Transplants Immediately. So Jerry Radich talked about the role of transplant and made the point that even though the incidence of CML may not be changing, the prevalence is rising dramatically because instead of people dying after 3, 4, 5 years, they're living much, much longer. And so there's a tremendous buildup of patient populations, and eventually a number of those patients are going to become TKI resistant and be candidates for allogeneic transplants. So what were your thoughts on his presentation?
Well, Jerry's animated and entertaining as always.
He has a great mustache.
Yeah, that too. He showed some actually really interesting historical data from Fred Hutchinson Cancer Center, where he works. You know, in 1998, CML was the most common indication for transplant there. They were doing 190 transplants a year for CML out of, 350 or 400 that they were doing. And 5 years later, it was almost completely gone after imatinib came on the market in 2001. But it didn't completely go away, and that's because there are still a subset of patients for whom transplant can be beneficial. Certainly those with accelerated phase and blast crisis, I think there's little argument that transplant is still the right thing to do for those patients. But what about the chronic phase patient? Well, it's rare, but there are chronic phase patients who just, despite your best efforts, can't tolerate any of the available tyrosine kinases. You should, in those cases, I think, make an effort to try to get the patient on a clinical trial, but sometimes there's just not an option for them to control the disease. So, that's a small number of patients, but there are still some folks. And then Jerry also pointed out that, since people are now living with this disease for decades, that is a longer period of time in which some event may happen, in which mutation may be developing and then give rise to CML. Or alternatively, other bone marrow diseases can evolve in those patients. I have some patients I've seen who were doing great from their CML, but now have myelodysplastic syndrome, just an unrelated thing. They were getting older and things happen. So there are still patients who do undergo stem cell transplant, but it's single digit kind of numbers even at the major centers.
And patients who develop the T315I, they may respond to ponatinib, but it's not going to last forever, or they may become intolerant of it, and omostaxine does not appear to be a long-term solution.
Right. Yes, I think that's another group for which there is a role for transplant, is those who do develop T315I mutations and then for whatever reason ponatinib doesn't work for them, or they're not tolerating it. That's another group that we would refer.
So David, tell us about all the new, amazing, and highly successful therapeutic strategies for MDS.
So we had a session today at the meeting on CLL, and I don't treat CLL, but I'm very jealous of my colleagues who do treat CLL in that their therapies are so effective compared to what we have in MDS.
Tremendous breakthroughs.
You know, they were, Matt David's CLL expert from my institution showed a comparison of FCR and ibrutinib, and 95% response rates for both of them, and huge CR rates. And we don't see that with azacitidine or things in MDS. So, we're struggling. MDS is a different kettle of fish, just because I think of the diversity of the mutations that drive it, the fact that it's something that's seen in the aging marrow, and a marrow that has limited healthy stem cell reserve in many cases. And the mutations that we have detected recurrently are not things that we can think of, oh, hey, that's easy to target. We can, tyrosine kinase activation is rare in MDS. It's things like splicing and chromatin remodeling and epigenetic dysregulation and transcription factors and P53. I mean, goodness knows, we don't know how to target any of those.
So what about IDH1 and IDH2? I mean, there are agents in trials targeting those metabolic pathways.
Yeah.
Is that going to have an effect in MDS?
It'll have a little bit of an effect in MDS. In fact, I just before I came here, I looked at a bone marrow on a patient of mine who's on an IDH2 trial who had MDS with RAAB, and just happened to have an IDH2 mutation on the molecular profiling. And so he has a transplant option. We gave him, we were able to enroll him in the IDH inhibitor trial, and his blast came down enough so that he's going to be able to move on to transplant. Unfortunately, that's uncommon. IDH1, IDH2 are just a few percent each in myelodysplastic syndromes. Much more common in normal karyotype AML. And so that's really, I think, the niche for those drugs.
So in addition to exploring the genetic abnormalities in MDS, what are the thrusts as far as clinical research, that you are interested in, or you see that have potential and hope in the future?
I think at the moment we're seeing really three sort of general themes in MDS. One is people are really looking hard to try to find drugs that are effective in the lower risk MDS patient for whom our available agents, erythropoietic stimulating agents and lenalidomide, are not effective. So that's a large group of patients, and it's a big unmet need. The second is combination therapies with azacitidine in particular. Is it possible to add a second drug to azacitidine and get deeper, longer lasting remissions? Azacitidine is one of the few drugs in oncology that's still used as a monotherapy. Right. Most diseases, at least, there's combination therapy. And the third is the patients for whom hypomethylating agents fail. That's really a group where there's a great unmet need. And we were a little bit disappointed that at the most recent ASH meeting, the rigosertib data was presented, and the rigosertib did not improve overall survival in that group. But there is still some interest in this agent. There's another trial that's going to be getting going, looking at a subset that did appear to benefit more of primary non-responders to an HMA. So there may be some options there, but that is really a very difficult group of patients, those HMA failures.
So what about the oral azacitidine agents? I know Guillermo Garcia-Manero was looking at that a couple years ago. Has much come out of that?
Yeah, so that agent, CC486, which is an oral formulation of azacitidine, is definitely moving forward. The study is still ongoing, and we haven't seen recent data updates, but it is still something that I think is very attractive to us as oncologists, in part because perhaps by using very low doses for longer periods of time, we might be able to obtain deeper or better remissions in patients with MDS. There's also now a oral formulation of D-cytabine that we're studying at Dana-Farber in conjunction with a few other centers, Vanderbilt, MD Anderson, And this actually combines decitabine, which by itself is not absorbed very well, with a compound called E7727, which is a cytidine deaminase inhibitor that allows the drug to be better absorbed and achieve better levels. So perhaps those two agents may end up changing a little bit how we approach hypomethylating agents in MDS. We just saw a preliminary data from Yogan Santararaja from Cleveland Clinic. He has this very low dose decitabine work that he's been doing for the last 5 or 6 years, using just 0.2 milligrams per kilo per day. And he claims to be seeing some very impressive responses with that. If indeed the drug is working primarily by DNA methylation inhibition, that occurs at a very low dose level. The cytotoxic activity occurs at a higher dose level. So maybe he's onto something. It's something that perhaps can be compared directly.
There was some data a couple years ago using higher doses of lenalidomide in AML and in those patients who were like 20% or more blasts.
Right.
Has that data come of anything as far as in high-risk MDS?
You know, lenalidomide in higher doses is tough for MDS patients to tolerate. And I think some of the more recent data that have come out in AML were a little less encouraging. So there was, you know, the SWOG study, for instance, where they looked at AML with del(5q) and used higher doses and saw, you know, a response rate, CR rate that was single digits. So I think there's not as much excitement as there was a few years ago about that. We'd also hoped that in MDS, by adding deacetylase inhibitors to azacitidine, that we could improve the outcomes. And all of the studies that have compared that approach have not shown any benefit from the combination. So we saw Mikhail Sakaris's S1117 study at the most recent ASH meeting. That was looking at AZA alone, AZA plus lenalidomide, AZA plus varinostat, and the AZA plus varinostat arm kind of did the worst. We saw just recently a press release about another deacetylase inhibitor, prasinostat. AZA versus AZA plus prasinostat didn't help at all. Didn't help. And this is on the background of Steve Gore's study from a few years ago, the ECOG E1905 study, which was AZA plus MS275, and tinostat, another deacetylase inhibitor. If anything, the combination was worse than AZA monotherapy. So the blush is a little bit off the deacetylase inhibitors. It's disappointing.
Oh, wow. All right, David, thank you so much. It's always good to get together with you, and I hope the next time we talk there is more exciting data in MDS. I'm sure there's going to be a breakthrough one of these days, and we'll see some real interest.
Can I mention one positive thing to end with?
Sure, absolutely.
So the one area where there is some excitement in MDS is in this lower risk ESA failures, because we have 2 drugs, so tadalafil, which has been developed primarily in the US, and luspatercept in Europe, which preliminarily had a 40% red cell improvement rate in people for whom EPO has failed. I think there's really something to it, and so I'm going to be watching those drugs very closely.
Very good. Maybe at ASH this coming year we'll hear more data.
I bet we will.
Very good. All right, thank you so much, and thanks to all of you for watching this segment of Best of the Day from the 2015 Great Debates and Updates in Hematologic Malignancies. Check back with us. We'll be talking about lymphomas tomorrow with Dr. John Leonard. Thanks again.